Hello, I'm Frank Stapleton, general dentist and dental software developer. My company, Efficient Dental Market Systems, is a stealth mode, bootstrap startup that, and I cannot lie, is more of a project than a living, breathing company. But that's all changing. After all, we were just awarded a U.S. patent in early December of 2016. Our software has two components: PerioQuik, a new method of rapid periodontal charting and analysis, and the Dental Integra platform for data gathering, storage, analysis, and dissemination of information interpreted from this data. The Dental Integra algorithm reduces 95% of all general dentistry diagnosis by volume into one spreadsheet. When combined with STL files, transforms a dental chart into a virtual patient, and creates the first evidence-based platform that connects all members of the dental community. I like to call this the Dental Informatics Superhighway. Typical practice management programs have two faces: business-facing functions versus clinical-facing functions. Our company's mission is to improve the clinical side of the equation. Modern clinical charting is a vast improvement over handwritten charts. Legibility and standardized notations were the start of what makes computerized charts superior. Portability and automated analysis of data continue the story. But when it comes to meeting the challenges of population health and clinical decision support, today's clinical software hasn't really progressed from the days of old. We still suffer from issues with interoperability and data siloization. Being connected by the cloud is only one part of the answer. Having a common language, standards, and vision for the requirements of a patient's record is even more important. The language that joins all global citizens is mathematics. Where structural relations can be described mathematically, consensus becomes a possibility. This is the basis of evidence-based practice. We are talking about three specific dental issues: tooth damage, periodontal damage, and temporomandibular joint damage, not the wide range of problems addressed by diagnostic code strategy. Some background. We start with the concept of ideal dental health. Tooth damage may occur to one or more of 5 supragingival surfaces, and generally 1 to 3 root surfaces. We will exclude third molars and teeth removed for therapeutic reasons like orthodontic therapy from the analysis. If a second molar is missing but replaced by a third molar in that position, the third molar is essentially considered as a second molar. Teeth vary in having 1 to 3 roots. For the sake of this analysis, we will consider all teeth to have the value of 2 roots. Therefore, the value of each tooth with respect to surfaces is equal to 7. When considering 28 teeth, the maximal value that represents ideal tooth health is 196 surfaces. Every damaged surface could be considered as an aliquot percentage from the ideal. At its most fundamental description, periodontal disease is evaluated on recession, pocket depth, bleeding, mobility, furcation involvement, and suppuration. Therefore, when you define 4 categories of tooth damage and compare each state to 5 categories of periodontal health, you can readily see that, with respect to tooth and supporting bone damage, in general, there are 20 unique states of dental health. Each unique category has only a small range of variation, and most likely would share common treatment strategies. Introducing PerioQuik, the solution to our profession's present-day periodontal health data gathering problem. Hippocrates said a few years back, "Without diagnosis there can be no treatment," and this holds true even today. But what kind of periodontal examination will you do? Are you aware that you have 4 choices? Yes, you do. But the first two are kind of non-starters. For sake of brevity, self-reporting and biological testing may alert concerned parties as to the possible presence of periodontitis, but they are not diagnostic for the determination of locality or severity of the disease. The third type of examination is what is referred to as a surveillance technique. The WHO developed the Community Periodontal Index, or CPI, as an examination technique for assessing population health, especially in areas that lacked access to modern technology like electricity. This method was soon modified and adopted in England as the Basic Periodontal Examination, or BPE. The U.S. version is PSR, Periodontal Screening Record. These are by no means comprehensive examinations, but rather screenings to rule out the discovery of periodontitis in an individual. PSR is a handy tool for identifying and documenting the presence of periodontal health, but it is not granular enough to be a complete record. I would go as far to say that PSR is more of a legal defense than health record. Said in another way, PSR is CYA. Here is the harsher reality. It is highly recommended by the American Academy of Periodontology that every patient have a comprehensive examination performed annually, and the AAP has very strong feelings that this examination include full gold standard charting. What does this mean? Complete charting includes 6 measures of clinical attachment loss around each tooth. That's gingival recession plus probable pocket depth. 4 to 6 notations of bleeding per tooth. Notation of tooth mobility grading where found. 4 to 6 notations of suppuration or pus, and evaluation of furcation involvement on the 10 teeth that typically have furcations. This is all to be committed to a dental record at each examination, both for treatment and legal reasons. Presume that we are to live in a future that does value the ability to manage population health. With all of today's computerized periodontal charts, this represents a massive amount of data. The research literature has found that under the best circumstances, full periodontal charting takes a minimum of 13 to a maximum of 25 minutes. Additionally, this charting may or may not be reimbursed by insurance. It is definitely not separately reimbursed on an initial examination, in that it is an essential and expected part of that service. So the direct economic motivation for dentists to gather this documentation is low. Also, take a typical health maintenance visit and break it up into tasks. How much time would you allow for each component? We all have different estimates of the times required, but we all know that health maintenance visits typically run from 45 to 60 minutes in length. So here's where EDMS might eventually be of service in reducing the overall time needed for recording, the stress with the collecting data, and chance of not communicating treatment need or motivating your patient to compliance with your recommendations. The Dental Integra software is an electronic dental chart with built-in expert systems designed to make your day just that much more pleasant and productive. Here's the PerioQuik data input form. It looks like a spreadsheet, right? Well, of course, it is. A spreadsheet devoid of the need for redundant and extraneous data. The formula for data entry is simple. Tooth number and issue examined. Recession and pocket depth is further segmented by surface examined. Then, each cell receives an appropriate value. For recession and pocket depth, it's attachment loss in millimeters. For bleeding and suppuration, it's a yes or no. Mobility is graded traditionally 1 through 3, and only furcations graded 2 or 3 are recorded. Here's what data entry sounds like. 18 RB3. For tooth number 18, there is 3 millimeters of recession on the buccal. 18 F2, or a furcation of 2, on 18. 18B, for bleeding on number 18. It doesn't matter how many points of bleeding. Bleeding is bleeding. 19. PD4, a periodontal pocket of 4 millimeters on the distal of number 19. 19. PM5, a periodontal pocket of 5 millimeters on the mesial of number 19. 20. M2, tooth number 20 has a mobility of 2. 21. S, tooth number 21 shows suppuration, better known as pus. This data entry technique virtually assures the accuracy of every entry. Corrections are surgical and simply require repeating the correct coordinates where errors were made. Even if every tooth had every problem possible, it would still require 55% less data for complete documentation than traditional full charting. With this periodontal coordinate exceptions reporting technique, only abnormal findings need be noted, saving even more time and effort. Once the PerioQuik form has been completed, we move on to its parent programming. Let's take a look at the dentalintegra.com. Here's the dentist's homepage. There is a section for courses on using digital data in diagnosis and a section where users can ask questions or make observations and suggestions for software enhancement. But it all starts by adding a new patient. The user can also be sent an email with a link to the registration page, or if they are in the office, simply click Add Patient. This can also be done by directing patients to your practice's website, where they click on a link asking them to register here. It takes them to a form for new patient registration or a login to a portal for existing patients. Back at the home page, our virtual assistant, Phyllis Form Filler, helps with the registration process. Patients are asked to fill in this screen. This is the basic demographic information commonly found on most intake forms. However, as you will see, unlike other programs that simply store this information, the Dental Integra can integrate this data into the analysis of the patient's dental health. And of course, we are HIPAA aware. Signed, agreed or declined, it makes no difference. The practice is only required to make a good faith attempt to inform. With this registration process, there can be no doubt of that attempt. Medical health information, starting with general information. Treatments that have consequences and you need to know about. Medications in brand or generic name. Finally, the patient's dental history, including complaints. Wrap it all up with a general consent form for treatment. Signed, accepted or declined, giving you a preview of the cooperation you might expect. Back at the home page, the dentist enters his or her profile. There will be a future section on analytics. This will include calculations on rates of tooth damage and periodontal breakdown. For if periodontal disease is episodic in nature of its destruction, this will be the first time you will have empirical, evidence-based data as to whether your patient is experiencing active disease at the time of the examination. No more waiting until the next checkup to see how it's going. No more standing on the sidelines as your patient's health deteriorates. This will also provide practice-wide analysis and comparisons to specific populations of interest. Let's say a referral was needed. Simply click the Referral section. Set up your referral card. Select your network of providers, and when you are in the patient chart and need to make a referral, click Refer to Specialist. Your referral network appears. Pick your provider. Choose the examination dates with the appropriate information. Choose one date or choose several. Then click Next. Include a note regarding the nature of the referral, then click Confirm and Send. You're done. Specialist receives all pertinent patient information, and patient will receive the specialist's contact information on a virtual referral card. Track referrals you've sent. Track referrals you've received. Back at the home page again. How do you know how to operate the program? I suggest clicking Start Here. Start Here has a number of short PowerPoints that teach the philosophy and operation of the Dental Integra software program. Want to include that cool patient registration feature on your website? Click Embedding. Simply copy this code and send it to your practice website's administrator to be added to the site. Tell them how you want the patient to be able to access this link, and they will know what to do. We've developed a couple of hacks to help with reading and interpreting X-rays. Click on Examine X-rays. Here you see a typical full mouth display. Click on any given tooth. And it enlarges for easier reading. Additionally, on the right, you see a checkbox of common radiographic findings. Check all conditions that apply. You will see later how these findings will be brought into a narrative report of examination findings. Back to our full mouth series. What's changed since the last full mouth? Well, to compare these X-rays to past films, just choose a date and the films of that examination will be displayed as such. Additionally, if you need to compare any old film to a new one, select the desired film, click Enlarge, and that film enlarges and can be moved against the new X-ray in question for better viewing. Back at the main chart, if we want to review an image, just select the image desired and click where it says Notes. The picture will enlarge for better viewing, and notes pertaining to this image can be made to the right. For those familiar with Diagnodent, you know that this is a great device for detecting occlusal decay, not often detectable by routine clinical examination or X-rays, but the manufacturer does not provide a data recording strategy. Findings must be manually entered into the chart. The Dental Integra provides a place for recording and interpreting findings. Soon to be available on this iteration of the software, as was available on a previous version, is the ability to alert users to sub-threshold findings that have increased in value by 10%. This allows the clinician to know that the caries breakdown is active and can be treated at the earliest opportunity. Finally, from all the information that you've gathered, let's put it together. Review of general medical status, overall diagnosis by topic, review of current medications and their oral health implications, medical complaints as they relate to dental treatment, dental complaint review, periodontal and hard tissue review, radiographic findings, temporomandibular joint pathology findings, Diagnodent findings, general discussion and recommendations. This is helpful to clinicians and patients alike. For example, within the program, we have compiled a drug database with over 200 commonly and not so commonly used medications. The program educates the user as to the oral health consequences of using these drugs. With medical conditions, the narrative speaks to best practices as they relate with respect to dental care. This obviously would be helpful to the less experienced clinician, but could also serve as a reminder to even the more experienced providers as to help reduce treatment errors. But at the heart of the Dental Integra software is its ability to provide objective, evidence-based analysis with respect to your patient's health status. Are they becoming healthier, maintaining their health, or deteriorating? Let's add a patient, only this time for real. To the left, above the blue banner of the patient listing box, type in the first or last name of the desired patient. You can also simply type the first and last initial. This will give you an edited listing of patients. Click on the desired patient. In this case, we will look at my favorite patient, Anita Flossmore. This is her simplified dental chart. On one screen, you are able to access tooth information, periodontal information, temporomandibular joint data, images, and radiographs. From this chart, I know that I am looking at a patient that is dentally perfect. The upper part of the tooth glyph represents dental structural integrity. The lower part of the tooth glyph represents periodontal integrity and support. Let's look more closely. On the tooth glyphs, at the bottom, you will see the current estimate of bone support. In this case, all at maximal values for each tooth class. The upper portion is white, meaning the clinical crowns of these teeth have been untouched. To make it even easier, just remember, green is good, yellow cautionary, and red is bad. Next, we look at the PerioQuik intake form. The dental integra theory is based on the observation that gold standard charting requires too much and PSR does not contain enough data. On the left, you'll see the tooth numbers. On top, you should notice the notations of R, P, B, M, F, and S. These represent the periodontal disease signs of recession, pocket depth, bleeding, mobility, furcation involvement, and suppuration. The clinician examines each of the four sides of a given tooth and notes the greatest value of recession and pocket depth. Bleeding is noted as present or not. Mobility is graded with the traditional 1, 2, and 3. Only furcations graded 2 or 3 are noted, and like bleeding, suppuration is noted as present or not. Here you see the Dental Integra score screen. This is the patient's scorecard. Their periodontal health is evaluated tooth by sextant, quadrant, half and whole mouth analysis. The Dental Integra score is not an integer number. Rather, it is a combination of two rankings. The tenths position represents the hard tissue health ranking 1 to 4, and the ones place describes periodontal health ranked 1 to 5. At the bottom is the percentage health of the hard tissue health HTH, and soft tissue health, STH. You will see in subsequent slides that the program alerts the clinician as to the health trends in addition to quantifying health and comparing visit-to-visit changes. Here, I know that the lower incisors are in trouble with moderate periodontitis, as indicated in yellow. The central incisors have lost approximately 9% of bone support, while the laterals lost 8%. Additionally, when you look at PerioQuik, you'll notice the bleeding notations which are then reflected on the Dental Integra dashboard. With the lower portion of the glyphs indicating moderate periodontitis, now the yellow on the top is equal to 2 surfaces of tooth damage. With about 15% tooth damage, the patient now enters the second level of overall tooth damage in addition to the periodontal changes in the maxillary arch. Now, in the upper portion of the tooth glyph, red indicates tooth damage on 3 or more surfaces. Clinical experience and common sense would have us believe that the risk of further complications, like the need for root canal or tooth loss, increase with additional loss of tooth structure. On the perio side, notice that the Integra score has changed from 2-1 to 2-2. This reflects gingival bleeding as being a dominant clinical feature irrespective of underlying periodontal damage. More tooth damage and less periodontal damage. With over 26% tooth damage, this patient is well into the next to lowest ranking of hard tissue health. With the elimination of bleeding, and despite having localized problems, this patient's periodontal status has returned to a full mouth rating of healthy. More tooth damage and some more periodontal breakdown. Now there is enough bone loss to merit an overall periodontal ranking of early periodontitis, but not enough additional tooth damage to change the hard tissue portion of the Integra score. additional tooth and periodontal damage. With greater than 50% tooth damage and significant additional bone loss on the mandibular arch, the patient is trending down into the lowest ranking for tooth damage and an overall description of moderate periodontitis. And here we push poor Anita over the edge with both extreme tooth and periodontal damage. With an Integra score of 4-5, poor Anita has bottomed out. The tooth-by-tooth analysis would suggest that she will be losing 20 out of 28 teeth due to periodontal disease. The multi-surface restoration notations raise the possibility of needing full coverage restorations for the remaining teeth. What happened to this young lady? With the Dental Integra software, you need not guess. To the left, you have probably noticed the hard tissue and soft tissue bar graphs. They will tell you the story. With the aid of this software, it was easy to envision her prognosis, but here we are trying to illustrate how the technology works. It is hoped that this data would dictate the necessary intervention needed to have prevented the sad state of affairs. Given this cautionary tale, let's conclude with these thoughts. You have just witnessed how data can model a patient's state of dental health, but admittedly, not all dentists will comfortably relate to such a data display and interpretation. Clicking on the button changes all of that. Now, STL files complement the data component to create a virtual patient. With every facet of health documented, the patient is ready for diagnosis and treatment planning, whether for traditional office treatment, referral, or teledentistry. The only thing missing from the process is touch and smell. Ultimately, this technology joins the 4 markets of our dental community. It helps the dentist organize information and market their recommendations. It helps patients via portals to control and manage their own dental health care. Interested third parties, like universities, government, and insurance carriers, get data useful for research, public health, and risk assessment. Finally, commercial vendors can target market patients in a HIPAA-compliant way as to partner in solving oral health problems. As they are introduced, other forms of digital data related to dentistry can be added to this platform for recording, analysis, and reporting. Nobody can predict the future, but I hope that I have brought some insight as to how we will be managing our patients' health through evidence-based diagnosis and record keeping. You now have an important decision to make, whether to engage with a technology that can provide greater focus and success to our efforts, or to simply embrace the status quo. As with all things, the choice is yours. Should you choose to join me, I invite you to set up an account at thedentalintegra.com. There are no costs other than some learning and your participation. I hope that you've enjoyed this program and look forward to having you join me in making decay and periodontal disease a thing of the past.